Hi, I'm Laura Boomer. I'm a pediatric surgeon at Virginia Commonwealth University in Richmond, Virginia.
And hi there, I'm Alexander Felice. I'm a pediatric surgeon at Le Bonheur Children's Hospital at the University of Tennessee.
Welcome to the 2021 Critical Care APSASode, Sharpening Your Critical Care Skills. Alex and I are honored to moderate this session. We will have 2 sets of abstracts presented and 2 educational panels with time for live question and answer at the end. Here are learning objectives for the session. We're going to begin with 2 sets of abstracts.
My name is Mike Dingledine. I'm a pediatric surgeon at Rainbow Babies and Children's Hospital in Cleveland, Ohio. And I'm introducing the first abstract. It's early prostaglandin use in CDH-associated pulmonary hypertension is associated with improved survival to discharge by Akila Ramaraj.
Thank you again for the opportunity to present our work. Our disclosures are unchanged. We know that CDH-associated pulmonary hypertension is a distinct entity compared to other forms of persistent pulmonary hypertension in the newborn. CDH-associated pulmonary hypertension often responds to antihypertensives differently than PPHN, and it can be challenging to identify optimal therapies for CDH patients as a result. As we've discussed, there are no standard recommendations for prostacyclin use in these patients, though there are 2 conceptual perspectives described here. Given our prior review of the CDH study group registry, our goal here was to evaluate clinical outcomes for early versus late initiators of prostacyclin therapy, using 7 days as the cutoff for early use. We used the same data set described previously, but this time we excluded patients who were admitted after the first week of life and those who never received prostacyclins. Patients were categorized as early or late initiators using the 7-day cutoff, and logistic regression analyses were used to evaluate the odds of survival to discharge for early versus late groups. We performed multivariate analysis to adjust for potential confounders of defect size and transfer status, and perform 2 different sensitivity analyses, one using a different cutoff for early initiation, and the other using a continuous rather than categorical definition of the start date. Reviewing the demographic characteristics of the study population, we see that the early and late initiators were well balanced on most factors except for defect size and transfer status. A greater proportion of early initiators were transferred in for treatment, and these patients on average had smaller defects. Comparing initial outcomes, we found that early initiators were less likely to require ECMO, had shorter duration of ECMO, shorter time on the ventilator, fewer days in the ICU, shorter length of stay, and improved survival to discharge compared to late initiators. Results of logistic regression analyses found increased odds of survival to discharge for early recipients versus late recipients of prostacyclins. This effect was enhanced after controlling for potential confounders of defect size and transfer status. When we used a 2-week cutoff point for early prostacyclin exposure, the survival effect was preserved. And we saw a similar preservation of the survival effect using a continuous start date for prostacyclins as a covariate, with decreased odds of survival associated with each subsequent day to start prostacyclins. As with any observational study, we cannot draw conclusions about causality from these results. Specifically, we can't comment on the ability of prostacyclin therapy to prevent ECMO or decrease the duration of ECMO because we did not account for timing of initiation relative to ECMO in this analysis. However, this is one of the first studies to evaluate early versus late initiation of these agents in the CDH population, and we did take care to account for limitations in the observational data set with our study design. So in summary, early prostacyclin therapy is associated with improved survival to discharge compared to later therapy, and these results were robust to various definitions of early therapy. Future work should clarify the effect of early prostacyclin initiation on the need for ECMO specifically. I'd again like to thank my mentor, Rebecca Stark, and the members of the CDH team at Seattle Children's Hospital, as well as the CDH study group for providing the data for this project and support throughout. I'm happy to take any questions, and my contact information is available at the QR code seen on the screen.
Why do you think the late group had larger defects?
Yeah, so I think there's a combination of factors going on. I think the late group might have represented a sicker group of patients, and late prostacyclin initiation is actually more of an indicator of the severity of illness early on than a predictor of some of these other factors. And I think that in these patients, prostacyclin may have been used as a salvage therapy to try and get them out of a more severe illness setting, rather than as an early initiation of therapy to get on top of treating pulmonary hypertension.
Why do you think there is a late group? For example, in these patients, were more other meds used, or is prostaglandin used as a pre-ECMO salvage?
So I think it's a combination of a couple of different things. We do know that there's institutional variation in how prostacyclins are used, with some institutions favoring early use of the medication and some institutions favoring late use of the medication. So I think some of it might be due to institutional variation. And in some patients, it's certainly more likely that this drug is seen as kind of a maintenance therapy to start later in patients who are unable to be weaned off of ECMO. And so for those patients, other meds are used early in the treatment course, and then prostacyclin is reserved for a later time period.
Was there a difference in the pre-ECLS ventilator choice between the early and late groups, meaning between the high flow and conventional?
This is something that's a little challenging to assess from the data set that we received from the CDH study group, because pre-ECLS ventilator choice was not captured for all of the patients over this time period. I think it was a variable for a portion of the time period that the data set spans and not for another. So it's challenging to know the extent to which that played a role in the decision to initiate prostacyclins.
Thank you, Kelia. Thank you for an excellent presentation, and thank you for answering our questions.
Thank you.
Hi there, I'm Yeet Gunner. I'm a pediatric surgeon at the Children's Hospital of Orange County, University of California, Irvine. Our next abstract is Trends in Use of Prostacyclin Analogs for Management of CDH-Associated Pulmonary Hypertension by Dr. Akila Ramaraj.
Thank you for the opportunity to present our work. Our team has no financial disclosures, but we will be discussing off-label use of medications. Congenital diaphragmatic hernia is caused by abnormal development of the diaphragmatic leaflets in utero. It occurs in 1 out of every 4,000 births and is associated with pulmonary hypoplasia and pulmonary hypertension. Pulmonary hypertension in these patients is different from pulmonary hypertension in other neonates. It can cause significant cardiac dysfunction, and 1/3 of CDH patients nationally require ECMO every year. Prostacyclins are potent vasodilators that have been evaluated in small-scale studies for use in the CDH population. Anecdotally, there are 2 conceptual perspectives regarding their use. The first advocates for early use to try and prevent the need for ECMO, while the second advocates for use in patients who are unable to wean off of the ECMO circuit or the ventilator. The purpose of this study was to evaluate patterns of prostacyclin use in the CDH population. To do this, we queried the CDH study group registry for all patients treated from 2007 to 2019. We reviewed the medications used to treat pulmonary hypertension with a specific focus on prostacyclins. We evaluated the characteristics of use seen here, including age of initiation, duration of use, and the specific agent used. Our initial data set contained 6,437 patients from 88 different institutions. In total, there were 604 patients who received prostacyclins in the data set, with a median start date of all prostacyclins of day of life 7. The majority of entries listed a generic prostacyclin, but when a specific agent was mentioned, treprostinil and epoprostenol, also known as Remodulin and Flolan respectively, were the most commonly used medications. From this data, we see variability in the median start time and duration for all of these agents, with some patients starting therapy as early as the day of birth. When we compared patients receiving prostacyclins to those who did not, we found that as a group, prostacyclin recipients were sicker than non-recipients. They were more likely to require ECMO, had larger defects requiring patch repair, spent more time on the ventilator, had longer stays in the ICU, and required more total medications to manage their pulmonary hypertension. Looking at trends over time, there is a slight decrease in the proportion of patients receiving therapy each year, although the absolute number of patients was relatively consistent from year to year. This suggests that the decreasing prevalence in prostacyclin use may be associated with an increase in the total number of CDH patients treated over the study period. There are some limitations to this work, most notably that many patients had a generic agent listed, so it's difficult to determine the most popular medication overall. We also did not have institutional identifiers, so we cannot say for certain that variability is at the institutional level rather than the patient level. That being said, there's only been one prior evaluation of prostacyclins that leveraged the power of the CDH study group registry. So in summary, we found that prostacyclin use varies among patients in the CDH study group, with the most commonly used agents being epoprostenol and treprostinil. CDH patients who receive prostacyclins represent a cohort of patients who are sicker than those who do not receive these medications. I'd like to thank my mentor, Rebecca Stark, and members of the CDH team at Seattle Children's Hospital, as well as the CDH study group for providing the data for this project and support throughout its work. I'm happy to take any questions.
Thank you. That was an excellent presentation. I have some questions. What do you think led to the variability in the start date of starting prostacyclin?
Yeah, thank you for that question. I think, like I mentioned, there's some disagreement about the optimal way to use these medications in these patients. And so some people and some institutions really believe in starting this medication early, while other institutions use it more as a salvage therapy for patients who are unable to get off of ECMO or off of the ventilator. I think other things that might play into this are concerns about bleeding in the perioperative period, which might incline some institutions to wait to use this medication once they feel those risks have decreased.
Thank you. Perhaps this is related to the first question, but what do you think is the relationship of prostacyclin start date and the use of other medications?
Yeah, so I think, compared to things like inhaled nitric oxide and milrinone, prostacyclins are on average started later, although they're on average started earlier than other medications like sildenafil. I think some of that is due to the incredible variability with which these medications are currently used, and some of it really has to do with the risks and concerns about use that I mentioned.
I also noticed that it appears that volume may be related to prostacyclin trends. What was the trends in other medications? Perhaps you almost alluded to this in the last question, nitric oxide, milrinone, as well as sildenafil and others.
Yeah, so we've discussed a little bit about the timing of initiation relative to the date of birth. Over the time period that we studied, we found a decreasing trend in inhaled nitric oxide use, starting at around 95% early in the study period and down to 80% late in the study period, and an increasing trend in milrinone use, so really a reverse trend. And these are really consistent with, I think, some of the literature that's come out about how to manage pulmonary hypertension in CDH patients.
Thank you very much.
You're welcome. Thank you again.
My pleasure to introduce our first set of speakers, and they will be discussing pulmonary hypertension and epic ventilator management. And our discussants will be Natalie Drucker, Howard Pryor, and Adam Vogel. Doctors.
Hello, I'm Natalie Drucker. I'm a resident at Indiana University and a future pediatric surgery fellow at UT Houston.
Hi, my name is Howard Pryor. I'm one of the pediatric surgeons at Le Bonheur Children's Hospital and Director of Surgical Critical Care.
Hi, Adam Vogel from Texas Children's Hospital.
Thank you for the opportunity to present on behalf of the Critical Care Committee. We're going to discuss pulmonary hypertension and the pediatric surgeon's role in this disease. Pulmonary hypertension is a disease process that pediatric surgeons need to be aware of. While we're not the ones typically Being the primary management of this condition, we do play a role in diagnosis. Often tissue diagnosis is necessary, and we as the surgeons have the opportunity to obtain that. Additionally, some of the treatments used for pulmonary hypertension can cause severe hypotension or cardiopulmonary collapse, and we are often required to put the patient on ECMO. This presentation will go through the importance of diagnostic pathway of pulmonary hypertension and the pediatric surgeon's involvement. First, let's talk about the definition of pulmonary hypertension. Pulmonary hypertension is defined as a pulmonary artery pressure greater than 20 millimeters of mercury. It can be further subdivided into pre-capillary or post-capillary, and this is based on the pulmonary artery wedge pressure being greater than or less than 15 millimeters of mercury. Pre-capillary pulmonary hypertension is also known as pulmonary arterial hypertension, and most common cause of this is persistent pulmonary hypertension of the newborn. Additional causes of this can be intrinsic lung disease that cause hypoxemia. Post-capillary pulmonary hypertension is often due to left heart failure leading to right heart failure or congenital heart disease. There's also multifactorial or undetermined causes that can be a kind of a combined picture. The first step in workup is often an EKG. The EKG will demonstrate right atrial and right ventricular enlargement, right heart strain, often bowing of the septum from the right to the left, demonstrating a overfilled right heart and underfilled left heart. And you'll also see right axis deviation of the QRS complex. Chest X-ray is often obtained next. While this can also rule out other causes of hypoxia or dyspnea, it can also show signs of pulmonary hypertension. On this AP film, you can see prominence of the central pulmonary arteries. On the left, you see the main pulmonary artery extending past the heart border. On the right, you can see the right inferior pulmonary artery is very dilated. And then there's a relative paucity of vessels peripherally as there's a quick cutoff from central to peripheral vessels. Also, you can see an enlarged right heart on the right image here, which further supports the diagnosis. The workhorse of diagnostic imaging in pulmonary hypertension is the echo. This can be used to estimate, to demonstrate the findings of right ventricular enlargement, left ventricular collapse, and septal bowing. You can also estimate pulmonary valve or pulmonary artery pressure, as well as the severity of tricuspid regurgitation. Echo can also look for other reasons for pulmonary hypertension, such as congenital heart disease, and you also can rule out any clinically significant pericardial effusion. CT chests are often obtained as well, again, to look for any other intrinsic causes or other causes of pulmonary hypertension. These can be things like structural abnormalities, thromboembolic complications, or other lung abnormalities. You can also see a dilated pulmonary artery, which further supports the diagnosis. Finally, to confirm the diagnosis of pulmonary hypertension, a right heart cath is 100% required. This will demonstrate and confirm the pressures that were often estimated via echo. The pulmonary artery pressure is greater than 20 millimeters of mercury, and this is confirmatory of the diagnosis. This diagram shows several access points to obtain access to the pulmonary artery. Now that we've discussed the diagnostic pathway for pulmonary hypertension, what are some of our options in treating it, Dr. Vogel?
Well, Dr. Drucker, that is an excellent question. And so for the next few minutes, what we're going to focus on is really the pharmacologic management of pulmonary hypertension. We're also going to talk a little bit about how pulmonary hypertension leads to right ventricular failure, and also what to do in a pulmonary hypertension crisis. And we'll spend a very short amount of time just on other options, non-pharmacologic options that are available. By far and away, the mainstays of pharmacologic management of pulmonary hypertension focus on three key signaling pathways, specifically in the pulmonary vasculature and the lung. And they are the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. With respect to the endothelin pathway, there are several medications that are available. The two most common ones that we've seen in our patient populations are bosentan and ambrisentan. These two medications differ in their selectivity for the endothelin receptor and their potency, and so they're often initiated in a staged manner. One of the most important aspects just to think about these different pathways in general is that all of these medications not only cause pulmonary vasculature relaxation, but they can also cause systemic vasorelaxation. So hypotension is a key side effect for all of these medications, and so that's really important to think about as these get started. The second pathway, which is probably one of the more ones that we're familiar with, is the nitric oxide pathway. And in this pathway, we really rely on phosphodiesterase inhibitors as part of the management. By far and away, the most common is sildenafil, but also tadalafil and vardenafil are also commonly employed, again, in that escalating fashion. And of course, we're all very familiar with inhaled nitric oxide. The third pathway is the prostacyclin pathway. And those pharmacologic agents are your prostanoids. And so these are quite very helpful and very widely applicable group of drugs. And one of the real benefits that they have is that they can be given intravenously, subcutaneously, inhaled, as well as oral. Epoprostenol and iloprost are probably the workhorses of this category, but all of these different meds can be used, and I think it's helpful for the pediatric surgeon to be able to look down the MAR and know what these drugs are, what class they apply to, and which signaling pathway they target. So when you think about these different medications, what we're really managing in all this is right ventricular failure. And I really like this diagram because it shows the impact of right ventricular pathophysiology, both with respect to hemodynamics and clinical symptoms as they progress from the asymptomatic phase, which is really just an increase in right ventricular afterload, as it proceeds through compensated right ventricular dysfunction and onto end-stage disease. And that pathophysiology is an increase in right ventricular afterload, increase in right ventricular wall stress, which leads to myocardial remodeling and eventually right ventricular dilation and failure. And of course, at any point in time, you can have a pulmonary hypertension crisis, which leads to acute right heart failure. And so this is really what brings a lot of these children with pulmonary hypertension to the hospital and into the ICU environment. And so when we think about the pathophysiology of pulmonary hypertension, we're really thinking about that pH crisis. So typically there's some sort of inciting event, whether it be hypoxemia, agitation, acidosis, infection, something along those lines. That leads to an acute increase in pulmonary artery pressure, increased pulmonary vascular resistance, and then right ventricular failure. That manifests as an increase in right ventricular and diastolic pressures and volume. That can lead to cardiac ischemia and arrhythmia. That can lead to septal shift and bowing into the left ventricle. That can create systemic hypotension and decreased cardiac output, which of course can lead to metabolic acidosis and just worsening the whole process. Right ventricular failure, of course, also leads to decreased pulmonary blood flow, can lead to VQ mismatch, and again, also lead to hypoxemia and respiratory acidosis, again, worsening this process. So how do we rescue patients from a pH crisis? Well, one of the first most important things to do is, try to deal with the inciting event. So if it's agitation, you can deepen sedation and paralysis. Try to treat hypoxemia by increasing the FiO2 on ventilator. We target a normal PCO2 and maybe a slightly alcoholic to optimize cardiac function. If they're not on inhaled nitric oxide, that's something that can be readily available and readily started if it's not already on. Inhaled iloprost is an incredibly useful adjunct that you can give as often as 20 minutes to try to reverse the pH crisis. Sodium bicarbonate for correcting acidosis, calcium chloride for helping with myocardial contractility, and of course, vasoactive agents. Typically in patients with pH, we're looking at intermittent boluses of epinephrine to try to improve cardiac output without actually increasing the pulmonary vascular resistance. And vasopressin can be used also in trying to shift that septum back over to the right side to try to optimize cardiac output. At the end of the day, these are really easy, not easy, but good options that we have for treating this. But there are lots of other interventions, okay? With regard to different catheter-based interventions, there's atrial septostomy, ductal stenting, and VSD creation that are all designed to offload that right side of the heart. From a surgical perspective, there's the pot shunt, which is a direct connection between the pulmonary artery and the aorta. Lung transplant is also an option for these end-stage patients. For pediatric surgeons, ECMO can be a really important tool in managing these patients in fulminant pH crisis, because we can essentially salvage them, allow for improved oxygen delivery and oxygenation, transient end that pH crisis, and allow them to get on better therapies. And so pediatric surgeons can play an important role in these critically ill patients in working with the ICU and putting these kids on ECMO. So obviously, these are all a lot of options that we have, but one of the most important options in managing patients with pulmonary hypertension is using the mechanical ventilator. And so, Dr. Pryor, what are some epic ventilation strategies that we have available to us?
Thank you, Dr. Vogel. Well, as you mentioned, the best method to treat a pulmonary hypertensive crisis is to avoid it. One of the key elements of prevention is avoiding respiratory acidosis and hypercapnia. So however many children at risk of pulmonary hypertensive crisis have a concurrent respiratory support need that exceeds the support provided by a standard ventilator, you start getting into complicated management strategies. Here is what would be relatively standard ventilator settings for a conventional pressure controlled ventilator. And I'll briefly touch on a couple of these things, but the primary thing to focus on is that inspiratory time, which is shown as the top parameter, usually has a ratio of inspiratory to expiratory ratio of 1:3, where the peak inspiratory pressure is usually less than 35 and the rate ranges between 12 and 30. Those two parameters determine your tidal volume and ultimately your minute ventilation. Whereas FiO2 and PEEP, which most people are familiar with, are methods for determining your oxygen delivery and kind of keeping the balloon open, so to speak, so that your surface area is available for oxygen transfer. We are comfortable tracking SATs with blood gases, frequent chest x-rays, and adjuncts of that type. In addition, kind of a newer technique for monitoring success with a ventilator is to look at lung ultrasound. And we showed just some representative pictures here real quickly. Picture A represents a normally well-inflated lung where you can see the pleural line and subsequent A lines underneath it, which represent ultrasound harmonic lines, showing that the lung is properly inflated and not full of a significant amount of interstitial fluid. The panel B shows when you have interstitial fluid that starts showing up as these thin B lines. And when you have compact lines, as seen in figure C, that shows that you've got kind of broad pore inflation. And the air bronchograms can sometimes be visualized as well, shown there in panel D. That said, the real focus here is to focus on methods for improving ventilation when standard ventilator techniques are no longer working, and you've confirmed with lung ultrasound that your lung is well ventilated and set up properly for success, or as good as you're going to be able to make it. So what is high frequency ventilation? High frequency ventilation is a technique where unlike conventional ventilation, it uses the momentum of airway pressure, the momentum of ventilation rather than airway pressure to get bulk exchange of gas through the airways. The common circumstance where you would use something like this is where you find heterogeneous or inconsistent compliance at high respiratory rates where conventional ventilators cannot manage hypercapnia. It's time to consider high frequency ventilation. A common circumstance is found with heterogeneous, inconsistent compliance in the lung. In order to avoid injury to the less compliant lung, high frequency ventilation is used. Examples where this might apply include children with bronchopulmonary dysplasia, congenital diaphragmatic hernias, and pediatric acute respiratory distress syndrome. And high frequency ventilation is a type of ventilation that delivers small tidal volumes with super physiologic respiratory rates. And the goal is to provide enough ventilation and oxygenation to the adequate and compliant lung while reducing the conventional ventilatory induced lung injury that would occur in the non-compliant lung using a standard ventilator. High frequency ventilation capitalizes on momentum rather than airway pressure for bulk airway exchange. And I'll show you an image in a couple of slides here that demonstrates a little more clearly how that's accomplished. High frequency ventilation strategies were first introduced about 30 years ago as a method for reducing intrathoracic pressure during thoracic and laryngeal surgery, but then were subsequently adapted to a variety of situations where high ventilatory pressures were undesirable, including pneumothorax and lung blebs. So the general principles of jet ventilation include that the jet delta P is the primary determinant of ventilation. The conventional ventilator provides PEEP as the primary determinant of oxygenation. And when you put a jet insufflator and a conventional ventilator together, it allows you to generate jet ventilation at high frequencies. You increase PEEP when you need to address inadequate oxygenation, or when you find that you are needing conventional ventilator breaths on a regular basis in order to expand lungs. And you decrease the conventional ventilator settings whenever possible, especially when air leaks are a common concern. So to be clear, the way that a jet ventilation system is set up is that a jet insufflator is placed in tandem with a conventional ventilator. Here's a general diagram of what that system looks like broadly. And this is generally considered an intermediate step between a conventional ventilator and high frequency oscillation. The conventional ventilator is shown here on the right-hand side, and its primary role in this system is to provide oxygenation through PEEP fundamentally. The jet insufflator, which is shown here on the left-hand side, provides the ventilatory rate in a very precise manner where the inspiratory time is measured closely. And they combine together in what's called this life port adapter, which connects to a normal endotracheal tube, which allows the two devices to be connected in tandem. Once in the inspiratory stream, what you'll see is that the jet insufflated air will move down the center of the airways with momentum, and the expired air will move at the periphery of the airway where there's less resistance. As shown in this picture here, you can kind of see the dark blue swirls or the expiratory air coming out. This generates less airway trauma and is a more efficient way to distribute ventilation across the alveolar regions that are available for ventilation. Some common jet ventilator settings are provided here. This is a very busy slide. I will just generally point out that the conventional ventilator's PIP is usually about 50% of what's required for the jet PIP when you set these things up initially. And the conventional ventilator rate is only set to 0 to 5 breaths, mostly to reverse atelectasis and maintain recruitment of lung that you already have recruited. The primary focus of that, again, for the conventional ventilators to provide oxygenation. High frequency jet ventilator management is better thought of in kind of a graph like this, where we look at just issues you want to address. So when the clinical issue is hypoxemia, you address that through increasing the FiO2, the PEEP, and temporarily increasing sigh breaths on the conventional ventilator, making no adjustments to the jet. When hyperoxemia is the problem, then you would take the exact opposite steps generally. For managing hypercapnia, you increase the delta P or the PIP on the jet. And when you have hypocapnia, you decrease the PIP and also would decrease or eliminate sigh breaths on the conventional ventilator. For air trapping, you decrease sigh breaths on the conventional ventilator and drop the jet rate. And for hypotension, your principal method for addressing hypotension is to drop the PEEP outright. So in this brief overview, we've just touched on the diagnosis of pulmonary hypertension, the treatment, both medical and surgical, some elements of patient assessment, and a method of using high frequency jet ventilation as one of your strategies to prevent a pulmonary hypertensive crisis. We'd like to thank the Surgical Critical Care Committee of APSA and our respective institutions for allowing us to present this portion of the talk.
Thank you, doctors, for a very educational presentation. I'd like to transition now to our second set of abstracts. Our moderators will be Jason Robertson and Christopher Newton.
Hi, everyone. My name's Jason Robertson. I'm a pediatric surgeon at Cleveland Clinic Children's Hospital.
I am Chris Newton. I'm a pediatric surgeon at UCSF Benioff Children's Hospital in Oakland.
I'd like to go ahead and introduce the first abstract. It's titled "The Effect of Volume Status and Early Renal Replacement as a Predictor of Outcome on Pediatric ECMO," and it's presented by Dr. Alex Garcia from Johns Hopkins Children's Hospital.
I would like to thank the APSA committee for giving us the opportunity to present our research. I'll be discussing fluid overload and early renal replacement therapy are associated with outcomes in pediatric ECMO. Acute kidney injury is common, with 30% incidence in critically ill children. It is associated with longer ICU stay and mechanical ventilation. AKI is also associated with a 4-fold increase in mortality if this occurs on ECMO. Fluid overload is also common in critically ill children, and prior studies have shown that fluid overload of greater than 15% is an independent predictor of worse oxygenation, longer ventilator times, and longer ICU stay. We sought to investigate the role of renal replacement therapy, or RRT, timing on outcomes in pediatric ECMO. We also sought to delineate contributing factors to mortality for patients on ECMO that require RRT. This was a retrospective single institution study over a 7-year period. We looked at all pediatric patients who were supported on ECMO, and we excluded those patients who did not survive ECMO for more than 48 hours. AKI was defined using the Kidney Disease Improved Global Outcomes, or KDIGO criteria, and severe AKI was defined as stage 2 or 3. Fluid overload was calculated using the daily total fluid intake and output recorded on the day of ECMO initiation, as well as on ECMO day 2. Early RRT was defined as RRT initiated less than 12 hours on ECMO, and late RRT was defined as RRT initiated after 12 hours of ECMO. We had a total of 136 patients in our study. We found that for operative cardiac patients, there was a higher incidence of RRT use within the first 12 hours of ECMO. We also found that patients who had a higher creatinine and a higher incidence of severe AKI had RRT use early within ECMO before 12 hours. We also found that RRT use was more common in patients with fluid overload. And we also found that survival was significantly lower for those patients who had RRT performed at less than 12 and greater than 12 hours. When we looked at survival to hospital discharge by fluid overload status on ECMO initiation, in red, you can see those patients who did not have fluid overload. You can see that those patients who had RRT had worsening survival, and this was also true for those patients with fluid overload. When we performed a multivariate analysis controlling for age, lactate, diuresis, AKI severity, and fluid overload on day 1, we found that those patients who had RRT had a higher risk of mortality, and this was significantly higher for those patients who had RRT performed after 12 hours. In conclusion, fluid overload at the start of ECMO was common, and levels higher than 10% were independently associated with worse outcomes. 73.5% of patients in our study underwent RRT during their ECMO course. RRT utilization was similar between survivors and non-survivors to hospital discharge. Controlling for volume overload, patients in whom RRT was used had worse survival than those who did not have RRT. Limitations for our study: we did not have any institutional policy on RRT timing or initiation at our center. These are my references. Thank you.
Thank you, Dr. Garcia, for a very clear and well-presented presentation. My question relates to the fact that respiratory ECMO patients may behave very differently than cardiac ECMO patients, particularly the operative cardiac population. Not to mention practice patterns in managing these different populations may also diverge. For example, in your presentation, 47% of patients going on CRRT within 12 hours were operative cardiac patients. Have you run any models that account for the type of ECMO or indication for ECMO, or have you just analyzed these groups separately?
Thank you, Dr. Robertson, for your question. While I agree all the indications for ECMO may cause a different outcome based on the indications for requiring CVVH, we did perform univariate, multivariate analysis looking at the different indications for ECMO, whether or not this was cardiac or primarily respiratory or postoperative cardiac, and we did not find any difference in our outcomes based on the indications for ECMO.
Dr. Garcia, thank you very much. I really liked your project and your presentation. It seemed clear to me from everything you presented that early CRRT in patients who were not initially fluid overloaded provided worse outcomes. What's not completely clear is if those worse outcomes were intrinsic to the CRRT itself, or did you find any evidence in your data that these were just sicker patients that were escalating as you were going on to ECMO?
Thank you, Dr. Newton, for your question. Certainly, CRRT or CVVH D in and of itself, we believe has some inherent risks associated with it. We do see an increase in thrombotic events for patients who are on CRRT. Our initial question was based on the premise that perhaps early fluid shifts that are done intentionally with CVVHD, may cause an adverse effect because the patient is not ready to tolerate fluid shifts. We did try to perform analysis trying to separate out patients who already had volume overload at the time of ECMO cannulation to see if we could stratify based on fluid overload, and we did not find a difference. And we also used lactate as a proxy for severity of illness, and controlling for that, we did not find a difference between the early and late groups. Thank you. All
right. For the next presentation, Dr. Alex Garcia will be presenting cerebral oxygenation is improved in children receiving blood during ECMO support.
I would like to thank the APSASode committee for giving me the opportunity to present our research. Our research is on cerebral tissue oxygenation is improved in children receiving red blood cell transfusion during extracorporeal membrane oxygenation. We have no disclosures to report. Red blood cell transfusions are common and associated with an increase in adverse outcomes in critically ill children. Red blood cell transfusions are standard practice on ECMO and driven by arbitrary hemoglobin targets. The Extracorporeal Life Support Organization, or ELSO, recommends maintaining a normal hemoglobin level. More recently, the Pediatric Critical Care Transfusion and Anemia Expertise Initiative, or TAXI, recommended using physiologic metrics and biomarkers in addition to hemoglobin levels in children on ECMO. Cerebral regional tissue oxygenation, or RSO2, as measured by NIRS, is a widely used marker of tissue oxygen delivery. We investigated the relationship between red blood cell transfusion and changes in RSO2 during ECMO. This was a retrospective single institution study that occurred over a 7-year period. Any red blood cell transfusion event was recorded if it happened at least 4 hours apart during ECMO. And we grouped the hemoglobin levels into less than 10, 10 and 12, and greater than 12. We began with a total of 175 pediatric patients that were on ECMO for at least 24 hours. 66 patients were excluded because they did not have data on transfusions or missing data on hemoglobin, RSO2, and lactate. The table on the right demonstrates the peak hemoglobin levels over the time course of our study. Under the table and under the graph in blue, we can see the pre-ELSO recommendations for blood transfusions, which at the time was for targeting a hemoglobin of 13. Under the red curve, you can see the more recent recommendations after the TAXI changes were employed, which recommended a hemoglobin of greater than 10. We found out of the 830 transfusion events, For those patients who had an RSO2 value less than 40% initially before transfusion, 28% of those patients had a change in their RSO2 out of the critical range. When we looked at the pre-transfusion RSO2 values compared to the changes over time following a blood transfusion for the different hemoglobin levels, you can see at the lower pre-transfusion levels toward the left of each table, there was a greater change in RSO2 following a blood transfusion. And this was consistent across all our hemoglobin levels. When we separated operative cardiac patients from all other ECMO patients, we found that operative cardiac patients did not have as much of a change in the RSO2 following a red blood cell transfusion as compared to other pediatric patients. In conclusion, among neonatal and pediatric ECMO patients, there was an increase in regional tissue oxygenation following a red blood cell transfusion. The effect was strongest among patients who had a lower cerebral oxygenation pre-transfusion. Changes in RSO2 levels may be related to other factors beyond red blood cell transfusions on ECMO. Limitations: we had a low number of patients in the less than 10 hemoglobin group, which made it hard to further stratify these patients into further subgroups. These are my references, and thank you.
Thank you, Dr. Garcia, for another excellent presentation. I have a few questions for you. The first is, when your institution switched to a more restrictive transfusion threshold, did you find that more crystalloid and/or albumin boluses were required to maintain adequate circuit flows? And second, what percentage of patients with a hemoglobin greater than 10 in the restrictive transfusion group met RSO2 thresholds of less than 40% that would indicate the need for additional transfusion? What I'm getting at is, how often did monitoring RSO2 change your management?
Thank you, Dr. Robertson, for your question. When we analyzed our data, we found that comparing our two groups, especially looking at our restrictive transfusion group, we did not find that these patients required an increase in crystalloid or colloids for resuscitation. When we looked at our restrictive group, we found that very few patients who had a hemoglobin of greater than 10 had a pre-cerebral oximetry saturation less than 40%. Currently, we do not use cerebral oximetry to guide our transfusion parameters or triggers, but our hope is that in the future we can use physiologic parameters such as cerebral oximetry to better guide the need for transfusion rather than fixed numbers. Thank you.
Thank you, Dr. Garcia. Again, a really nice presentation and really nice work. If I understand your presentation and your data correctly, your groups were collected in two different time periods, which had different hemoglobin targets that were consistent with ELSO standards at those times. The end result of this is you had a relatively large proportion of patients in your data that were transfused, but had hemoglobins over 10 and RSO2 values that were not too bad. And of course, you showed that that didn't make a huge difference in their subsequent RSO2 levels. This makes me question the utility of liberal transfusion therapies. And maybe during those periods, we were just giving too much blood. Did you find anything in your data to suggest that that liberal transfusion platform had negative outcomes or complications?
Thank you, Dr. Newton, for your question. I certainly agree that many of the patients with hemoglobins greater than 10 or in our liberal group certainly did not necessarily need a blood transfusion. And within our study, we did not find any detriment to this extra blood transfusion that may or may not have been necessary. But the literature does support the risks of blood transfusions. And I think that we need to be a little bit more careful and a little bit more judicious in our use of blood transfusions. And our hope is that in the future we can find physiologic parameters that would better estimate or help us get a sense of which patients would actually benefit from a blood transfusion. Thank you.
Thank you.
Thank you.
Thank you both, and thank you, Dr. Garcia, for your great presentations. And we're going to move now into the last section, which is a conversation about anticoagulation and ECMO with Dr. Keith Thatch and Dr. Sabina Siddiqui.
Thank you, Laura. My name is Keith Thatch. I'm one of the pediatric surgeons at Johns Hopkins All Children's and also the Tampa Trauma Medical Director at Tampa General Hospital, here with my partner.
Hi, I'm Sabina Siddiqui with Saliha Medical Enterprises. I'm currently contracted at Arkansas Children's Hospital and the Chief Medical Officer at Brio Device, a medical and device innovation company.
And on behalf of the APSASode Critical Care Committee, we are going to talk about anticoagulation strategies for ECMO, and in particular, looking at heparin versus bivalirudin. Neither of us have any relevant disclosures on this current talk, but we did want to note that there is no universal standard for ECMO coagulation management.
Now, to set the proper context for this conversation, we do have to remind ourselves that the question of anticoagulation on ECMO is not a simple equation of 1 + 1 = 2. It's rather a very complex interaction in your critically ill coagulopathic patient and the plastic of an ECMO circuit and the natural coagulation pathway as well. Now, unique to ECMO is the contact activation, which triggers the intrinsic coagulation pathway, activating factor 10, which is then the first common step in both the intrinsic and extrinsic pathways. But also, you have triggering of both pathways through multiple other exposures, including exposure of tissue factor by deformed cells and proteins bound to the plastic of the ECMO circuit. These coagulation abnormalities become increasingly more complex when you think about how the circuit is primed and how you can get a significant dilutional coagulopathy with a clear primed circuit, in addition to the other mechanisms that are displayed in this graphic. The impact of this complex cascade is what it means clinically, right? And bleeding and thrombosis remain significant complications associated with the worst of the outcomes for our ECMO patients. Per this ELSO registry report, 11% of neonates will suffer from intracranial hemorrhage, about 1/3 from surgical site bleeding, and 1 to 2% from GI hemorrhage. In addition, you have all the clotting complications that can happen. And these will significantly increase the mortality of these particular patients. And as we look at even more recent data, still about 1/3 of patients will have bleeding complications and 1/3 thrombotic complications. This pans out in peds and neonatal populations, and these impact our overall survival. So the question arises, what are our best practices to manage bleeding and clotting with the ECMO circuit?
So what do we do? I think that we use the all-stalwart of heparin itself. I think we all have become familiar with them, but we also are familiar with the problems. And so are there other possibilities? Are there other factors such as direct thrombin inhibitors and bivalirudin that may have some promise for our future in our anticoagulation strategies on ECMO?
And so just to remind us all, heparin has been the therapeutic of choice since the advent of ECMO therapy. Upon survey of ECMO providing institutions, we recognize, and it's been documented, that heparin is used by almost everyone. And while alternative anticoagulant therapies are starting to gain traction, they remain secondary options with limited experience and limited data available to guide our clinical choices. As the most commonly used anticoagulant, most of us are familiar with heparin's mechanism of action, as well as how it helps. But to remind us, it potentiates the anticoagulant effect of antithrombin 3 by forming a complex that inactivates free thrombin and prevents further thrombin generation. In addition, it inhibits factor 10A and binds other plasma proteins. Most folks are familiar with the advantages, therefore, including its low cost, its short half-life, the ability to reverse its action with protamine. Institutional familiarity makes it easy to titrate for us. And unique to heparin, though we don't discuss it, is its anti-inflammatory effects. It counteracts some of the mediators of the contact pathway, inhibits reactive oxygen species generation, has tissue repair and protective properties, and is thought to have cardiovascular protective effects. Now, we also recognize there are disadvantages, a lot to do with its unpredictable response at times, as its pharmacokinetics do depend on disease severity, your functional renal status, the volume of distribution, its variation in binding proteins, as well as variation in manufactured batches, and most significantly, its reliance on antithrombin 3 for its clinical efficacy.
That just seems like a lot, Sabina. We're talking about needing a cofactor, needing an antithrombin 3. Why can't we go directly to the source? So why can't we take these direct thrombin inhibitors, and bivalirudin in particular in this case, and go directly at thrombin and block that? Bivalirudin is easy to use. It has linear kinetics. It is not protein bound, so it has very few drug interactions. It inhibits both soluble and clot bound thrombin and blocks thrombin mediated platelet activation aggregation. On top of that, it has a very short half-life of only 15 to 25 minutes. And so it doesn't need an antidote. When you look at the pharmacokinetic side of things, from its elimination, this elimination is predominantly achieved by proteolytic cleavage, although 20% requires some renal kind of elimination as well, which we do need to monitor in some of our renal patients. But overall, it's a good, small kind of amino acid polypeptide that works well and works directly at the source of what we're trying to stop.
And that sounds very promising, Keith, but I mean, I want to remind us all, just because a new drug is out there, it doesn't automatically speak to its superiority of use or efficacy. I mean, heparin is an established therapy with a low cost for the cost of the drug. We're all familiar, even though it's complex, with how it works and how to manage it. And again, it has a rapid action, reversibility, and short half-life. And unique to heparin, which, you know, it is, I don't know of any other drug that can provide this, is its ability to inhibit the contact pathway, which contributes to the thrombus formation specifically on ECMO. And due to their direct interaction with thrombin alone, DTIs aren't known or thought to provide this functionality. In a randomized control trial in adults with artificial heart valves, an oral DTI was compared to warfarin, and it actually showed an increase in stroke and bleeding events in patients on the oral DTI. And the authors believed in their discussion that this was due to the fact that, unlike warfarin or heparin, the DTIs don't provide the inhibition of the contact pathway. So when you have that biomechanical and human interaction, heparin provides a unique advantage. But of course, you know, there are pitfalls. I mean, you have very high heparin requirements in neonates, which can affect your fluid status. You have a frequent need for adjustments and monitoring. You have reliance on antithrombin for effect. Its protein binding can also limit your ability to assay it. And, you know, this is all known, and Bob Bartlett often refers to it as a dirty molecule, but we're surgeons and we can work with what we've got, right?
Absolutely. I think ultimately, though, when we talk about the contact pathway or whatever we're talking about the ability for thrombus formation versus bleeding, right? We're trying to find that middle ground. And so I think a lot of this look at direct thrombin inhibitors was generated by the cardiothoracic literature and looking at stent trials, looking at CABG trials, looking at all the different things on pump, off pump, using of anticoagulation. And if we look at those studies, we show some promise with the direct thrombin inhibitor and bivalirudin in particular. And as we look through these studies and we look at the BAT study, they demonstrated there was a decreased death or MI or major hemorrhage in the bivalirudin group comparatively to heparin. When we look at the CASHIT trial, they also showed that there was a lower combined incidence of death, MI, revascularization, or major hemorrhage in the bivalirudin group. In the REPLACE trial, again, they showed that bivalirudin was superior to heparin alone, showing a significant reduction in the incidence of bleeding and thrombocytopenia. In the New Zealand clinical trial, they demonstrated that graft patency was improved in the patients receiving bivalirudin. And in the direct thrombin inhibitor trialist group, they showed that DTIs were associated with significantly reduced MI in these groups. So we saw significant promise, and in ones that are using anticoagulation for majority of their procedures.
I mean, that's a lot of data, Keith, and it all sounds really cool, but let me ask you, who actually dies of an MI in our patient population while on ECMO? let's refer back to that slide I showed earlier of what our complications are. And, oxygenator failure is on here, thrombosis is on here, bleeding is on here, but no one's actually dying of an MI. So kapow, friend.
All right, fair enough. I'll take that. I think that's fair. So let's talk about ECMO. Let's talk about bivalve and heparin and ECMO, and let's talk about some of the studies. So here in particular is a case study done by Pierre et al., and they looked at bivalve versus heparin on ECMO. And we see in their study that we demonstrated that heparin demonstrated that it had more frequent PTT variations, greater than 20%. So more changes of their heparin values needed than bivalve, and therefore caused more lab draws, more other things. Heparin also required increased number of corrections, as I'm saying here, with that anticoagulation dose.
All right, well, let me just throw this out there. On your slide, bleeding, thromboembolic complications, ECMO duration, mortality, none of those were different between the two groups. So boom, my friend, what is the clinical impact on the thing that we're really trying to affect?
Fair enough. Equivalence, right? You're talking about equivalence with a couple positives. Well, fine, boom. I'll take that, but let's look at a couple other studies then. So let's look at Ravicchetti et al., who looked at VV ECMO patients in heparin versus bivalirudin, and their results demonstrated that the bivalirudin group showed an overall decrease in the number of circuit thrombotic complications. Okay, so we're talking about the cardiovascular showing decreased hemorrhage, and now we're talking about decreased clotting as well. So we're finding that happy middle zone. Heparin showed an increased risk of clots. Bivalirudin also received a significantly less volume of packed RBCs, FFP, platelets compared to the heparin group. And there was overall a significant decrease in the major bleeding events in the bivalirudin group. So we're finding a happy medium maybe better in bivalirudin, at least in this study. We look at another study, again, looking at both adult and pediatric ECMO patients and over 400 patients, consecutive patients on ECMO. We saw that the main finding of a reduced mortality in the adult bivalirudin group. We also showed that there was a significant reduction in the composite transfusion requirement in the first 24 hours for the pediatric bivalirudin group. In another study, and specifically only in pediatrics, where we were looking at bivalve versus heparin, they looked at by Hamza et al., saw that there was overall a time to reach that goal anticoagulation layer. It was really important, kind of finding that time frame was shorter in the bivalve group. They also demonstrated that the bivalve group had a lower amount and fewer bleeding events. And when they really looked down at the data, when they truly looked at everything and looked at the comprehensive cost of everything and looking at the anticoagulant, the laboratories, antithrombin 3 costs, they actually demonstrated that heparin anticoagulation therapy total cost was significantly higher than bivalirudin. And I'll show again this later. In our own institution here at Johns Hopkins Health Children's, we have used bivalirudin for several years, and this is just our research and our data on the first 40 plus patients of CDH patients we put on, and our algorithm with this and our protocol shows that we start bivalirudin with all of our patients at 0.16 mg per kg per hour, and we titrate this in 10 to 20% increments with a target PTT of 70 to 85 seconds and a tag with our time of 9 to 12 minutes. With this study, we've demonstrated that all patients were able to get to their target anticoagulation levels within the first 12 hours. So I think that we're showing some superiority, maybe. And I think in the same vein, and I don't mean to completely poke fun, but obviously I do. If we look at the 90s, and you can have your flip phone, I'll give you your flip phone, I'll give you your old camera, I'll give you. Look at all these fun devices. I won't talk about the roller pump or the wedge, but anyways, but I'd rather kind of directly join the future. Let's go with our direct thrombin inhibitors. I don't mind my phone telling me where to go. I like my Theragun. I think there's a lot of advantages of thinking of what's new, what's greatest, what's best, how do we evolve, how do we push the boundaries.
Okay, Keith, but sometimes you don't just rush into the new. And I'm an innovation person, so I'm all about moving into the future. But I also, because I'm an innovation person, know that like Starbucks Cola and Colgate frozen foods and male rompers might be a nice concept and thought. It doesn't mean it's the right solution for the right time. And though you might be able to pull off the questionable fashion choice of the male romper and the dad jokes, because really, Keith, directly, it may not be the stylistic choice or even the right choice for everyone and the patient you're currently taking care of. And, you know, you've represented some really great data, but right out of Jacksonville, you know, we had a trial that looks at, you know, heparin versus bivalve in ECMO, and you know, they noted similar rates of thrombosis, major bleeding, and mortality events in these patients on ECMO. So, you know, I think there's data to support both sides at this point, and not something that clearly shows superiority.
Let's go right back to that same study real quick, and let me just highlight that last little line that you failed to kind of mention. That it says, however, it also observed that the bivalent group consistently maintained a PTT within the target range compared to heparin. So there, you know, yes, I think that we obviously want to have that effect of heparin. We want to be as good as heparin. Can we be better? And so I think there's potential to be better.
Fair enough. But let's, again, because we keep talking about all these studies, let's put that into context. So this is the number of studies that have actually looked at this exact question in PubMed over the last few years. So in this 9-year period, you can see that there's a bit of a paucity of studies. So to give you an understanding of the height of the graph, in 2020, there were exactly 8 studies that looked at this particular question. And similar to the study that your institution put out, not a single one was a comparison study. So it's really hard to, you know, say that we have good evidence that this is, you know, the way we need to go. And then I'd also kind of like to have us think a little bit about, biases and effects of running a study. And perhaps what we're seeing is not maybe the benefit of bivalve, but maybe a benefit of protocols, because one of the studies that is out there is just looking at heparin and heparin monitoring for ECMO. And when you institute a protocol, not only are you able to show a decline in major bleeding events, but also significantly less mortality and specifically retroperitoneal bleeding in the post-protocol group. So maybe some of what we're seeing, especially since we don't have strong randomized controlled trials, is maybe just the benefit of a protocol. So, with that, I just kind of want to remind us, and because we need to hear it a few times, is that, heparin remains familiar. It's the universal anticoagulant specifically for pediatric ECMO. We know how to use it. We know it's reversible. Because of our institutional knowledge of it, we know how to titrate it despite its complexity. And the price of the molecule is low cost. And yes, it requires antithrombin 3 for efficacy. And can cause platelet activation and dysfunction. It only inhibits that one particular thrombin molecule when it's free, and it can be associated with heparin-induced thrombocytopenia. But in almost 20 years of practice, I can tell you that I've only seen a handful of these cases.
I think that's fair. I think it's important to highlight the pros and cons of both. And I think if we look at bivalirudin, what is truly known, well, we know that there's no cofactor generally needed. We're taking out that antithrombin 3. We know that it inhibits both circulating and clot-bound thrombin. So functionally, it goes right at the source. It blocks thrombin-mediated platelet activation and aggregation. And is it the treatment for HIT? So is it the treatment of HIT? So why not go to it first? Again, highlighting the fact that it has a short half-life, 15 to 25 minutes. To the con of that is, yes, there's no reversal agent, but do we truly need it within that time frame? We're talking about heparin with a 90-minute short half-life. And the other part of bivalirudin that's highlighted by Sabina here is that, yes, there's not a robust amount of literature, and we need to do better about that. And so there is kind of a lack of familiarity both on the nation and kind of worldwide with the use of bivalve. There is some evidence, there is some increasing dose requirement over time to maintain that. But overall, as you said, as we've seen in the studies, the PTT range stayed better in the bivalirudin groups. And underlying coagulopathy, looking at the INR, is not the easiest thing with bivalirudin, and some of that is we can improve with as we use this better and better. And then the question of the cost, like what is the true question of the cost? The drug itself is more expensive than heparin, but if we look at the true cost and we look at the nuances of cost, we can question that a little bit. And so if we question that a little bit. And if I look back to Hamzo's paper at all, we look at their paper and they look at the true cost analysis, looking at the antithrombin 3 costs, the cost of the anticoagulants and the labs. When we look at that in specific, we see here heparin costs $1,200 compared to $500. And so actually the cost of bilirubin actually is smaller. And so maybe this cost isn't that big of a deal, or maybe that bivalve is actually cheaper. But in reality, Sabina, what does this cost matter in ECMO?
Well, and that's a good question. I mean, you can break down the components of one anticoagulation strategy against another and kind of add dollars here, subtract dollars there. But I mean, the context, again, of what we're talking about is the sickest patients in the ICU. They have failed all conventional therapies. And the mean hospital charges per hospitalization of these patients is in the $700,000 range, with an upper limit in the millions. And so when you talk about millions of dollars, I mean, is $500 a significant amount of money? And is it really just, spitting in the sea? So when you kind of look at that, it doesn't plead to me that we need to give up heparin, because again, it remains familiar. It is reversible with protamine. It has a relative ease of titration. It does require some cofactors to work, but we can keep an eye out for them. We know when to use them. We can create protocols around that. It inhibits the contact pathway, which is key with that human biomedical or non-biologic interaction. It has an anti-inflammatory effect. Yes, it has a small risk of heparin-induced thrombocytopenia, but the drug itself is actually low cost and easy to access.
And I'll give you that the bivalve data is limited, but I think we've seen safety. We've seen safety in the cardiothoracic literature, and we're seeing that in our ECMO literature. There is no reversal agent, but again, shorter half-life, 25 minutes. We do have more predictable pharmacokinetics. Maybe there's an increased dose requirement over time, but I think that we've shown in our institution, and I think more institutions are starting to see that we can do that. We can watch that. It does have a direct, clean mechanism of action. It doesn't need antithrombin 3. It doesn't need a cofactor, and it also is a treatment, and one of the treatments for HIT. And then if you look at the true cost, is the cost really more, or is it actually less in the aspect of what we have to do for the patient, what we have to give the patient, what labs we have to treat? So I think that I agree with you, Tamina. I think that we need every tool in the toolbox, so to speak. I think we need to be able to be ready, but I think that this offers some advantages, and I think it needs better studying, and I think more institutions are apt to use bivalve in place of heparin.
And you make a good point about institutions, right? So I think as long as you are working within your institution and you've had a thoughtful process and a thoughtful way to do it, I'll give that, bivalve might be a viable option, but heparin also remains a good option. And you need to use the tool you're comfortable with. You need to build protocols around them. You need to make sure that you have the appropriate bedside tests available. And then you just continue with the best recommendations straight out of ELSO. Evaluate your circuit, evaluate your patient, come off when you're ready in order to get the best possible outcomes for our patients. And that's really what we want, right? I mean, we can agree on this.
Absolutely. And we wanted to thank the APSA Critical Care Committee for giving us this time, and hopefully we provided some education. Thank you. Have a good night.
Thank you.
Thank you again to all of our panel and all of our presenters today. We are now available to answer any questions.
I'd like to thank the APS membership for joining us in this very informative APSASode, and we appreciate your feedback during the question and answer session. I'd like to also thank all of our speakers and abstract presenters. It's been our great pleasure to host you in this APSASode, and we look forward to further sessions with you. Thank you and good night.
Thank you all so much for coming to our panel today. Please, if you have any questions for this group, they're here to answer your questions live today. So while we're waiting for questions to roll in, my first question that I'm going to pose to this really smart group of people is, Sabina, what do you think would be the best way if an institution wants to try to institute using the direct thrombin inhibitors as their primary mode of anticoagulation for ECMO? How would you recommend they go about that?
Thank you for your question, Dr. Boomer. But before I answer that, I just want to address the commentary by Dr. Gattopalli about PENG and comparing it to heparin. I do want to point out that PENG still has a role in therapies, and just because you have vancomycin and meropenem, you don't use it for every patient. You're very thoughtful in which drug you use for which patient. That being said, I'll speak for Dr. Thatch, who couldn't be with us at the panel today, but just like any process you want to bring into your hospital, it's important that you need to make sure that you've identified and brought all the key stakeholders to the table when you want to institute a new protocol. And that's going to include people like pharmacy, your lab, your ICU nurses and perfusionists, and then all the physicians involved, whether it's cardiology, ICU, pulmonology, and even maybe hematology. Anyone who has a role in the successful management of your ECMO patient is going to need to have a role in developing this protocol. And then, you bring that multidisciplinary team a template to work with, and a good place to start is probably the protocol that Dr. Thatch's group put out and within their article. But then you need to make sure that every aspect of that protocol is relevant to your patients and your institution, that the tests are available at your institution, that your bedside practitioners are comfortable with and understand the nuances of the tests and how to apply them for the patient. And then once you do that and you have everybody on board and you have done an education process where everybody's familiar with it and has buy-in, then as you follow through, you need to make sure that you have a QI process in place so that you can identify where this protocol is succeeding and where it needs improvement or work. And then if anyone else has anything else to add.
Any thoughts from anyone else?
I just say I totally agree. I think with any time you're bringing something new into your institution, I think it's important to realize that, we all have a lot of friends in lots of different places. And if that's something you want to bring in, a phone call to Dr. Thatch or a phone call to Dr. Kays or their group, one of the great things about the pediatric surgery community and including the pediatric surgical critical care community is that, help is just a phone call away. And, if other groups have already been through that process, other groups have made mistakes and then had that experience, and we all can learn from that as a community. And I think that's really important. It's something that I think do all the time with, a lot of people on this conference call. So.
Yeah, Adam, I think that's a really, really great point. In line with that, what do you think the best take home from our session would be for the pediatric surgeon that isn't like those of us that are sitting here that hasn't spent that extra time doing some critical care training?
Well, I think the first thing that I bring up is that just within the field of pediatric surgery, we take care of a ton of critically ill patients. And I think every pediatric surgeon knows a heck of a lot more critical care than they probably give themselves credit for. And I think one of the important things that you can do, and one of the takeaway points from this session, is that critical care is constantly evolving, and those evolutions really do impact how we take care of our patients in collaboration with the intensivists in the ICU. And so I think keeping an open mind in the ICU environment, building relationships in the ICU environment, and really, when these issues impact your patients, learning more about them, and again, potentially phoning a friend in challenging situations. I think when we look over the abstracts and the discussions and some of the other talks that are there, these are all things that we as pediatric surgeons deal with every day and how we take care of our patients. And so there are lots of resources out there to help us do that. And I think when I look back over the session, that's what really, I think, speaks to me most prominently. That's what I took away from it.
Alex, what do you think? What's the biggest take home for the non-critically care trained surgeon in this session?
I think our goal is to really establish that our pediatric surgical community is knowledgeable on all these highly technical aspects of this. So I think being able to speak on different forms of anticoagulation, different forms of ventilation, really helps our community and helps our partnership with our critical care colleagues. So, and that's really what I'm proud of our committee, is that we're able to provide that education.
So Howard, talk to me about how in your institution, or how you would recommend the rest of us stay involved in the critical care management, particularly in the ventilator management of surgical patients in a PICU or an otherwise mostly medically managed ICU.
Thank you so much for the question. I think the most important aspect is bedside presence as much as possible. Asking questions, spending some time, investing a little bit of effort, understanding what your patient's ventilator needs are exactly is very helpful, which is some of the stuff we tried to cover in today's talk. It really comes down to the basics of oxygenation and ventilation, and then the modes are just, methods for accomplishing those two tasks. And I think if you're asking questions and have established, like Dr. Vogel recommended, a collegial atmosphere in your ICU, everybody's goal is just to get the baby better. And if that remains the focus and you're asking reasonable questions, I think it's anyone can have a reasonable conversation about ventilator management.
All right, Mike, I have to ask you to address Samir's questions in the chat, since he's the only one that engaged with us very deeply. So talk to me about what you think about what he asked. So for those of you watching this later, he's specifically asking about what do we think we can predict which CDH patients may benefit from pulmonary vasodilation, whether that be via initial X-ray or initial echo, ultrasound. What do you think?
Yeah, he's asking about that, I think, as imaging as a predictor of who might benefit from it. I know it's an interesting question. I hadn't really thought about it before. I think it's hard for complex kids that are sick like this to take one piece of data and make a prediction based on it. So you might be able to look at initial X-ray and think, this patient's not going to do great. But if their gas looks great, I don't think I'd necessarily start vasodilation. Adam brought up in the chat the question of, well, how about the doing an echo, an initial echo? And the question then was, well, all the echoes look bad. They're still transitioning. They all have some element of pulmonary hypertension. But I think there's probably a scale there of ones that you would expect to have some baseline pulmonary hypertension from birth, as opposed to ones that are really bad. So I think maybe the echo might be more interesting to look at than the chest X-ray itself. But again, I think it goes back to actually putting it all together and looking at all the pieces of data and not just trying to predict something based off of one number or one image. Samir, if you're still in the chat, feel free to rebut that.
Sabina, what do you think? What do you think about that?
I tend to agree with Mike here. These patient populations are really complex, especially in this day and age. A chest X-ray seems a little too literally two-dimensional to help you understand the multifaceted nature of what's going on with the pulmonary hypertension and how much of a role it's playing compared to your hypoplasia. I think, Mike also did bring up an interesting question of whether lung volumes might help us predict what role pulmonary hypoplasia may be playing in the whole picture. But again, I think that's just through anecdotal experience and, the last scouring of the data, there are just many, many elements here. And I think anything that we're going to look at is going to have multiple variables factored in.
And even not even just looking at lung volumes with the ultrasound, but even trying to look at the characteristics of the parenchyma. Again, I think that'd probably be challenging initially after birth as they're still transitioning and you have relatively consolidated lungs. But also something else that could be interesting to look at that could give you another piece of data around a complex kid. And as Samir just said in the chat, probably still won't stop him from studying it, which is fantastic. It's great to look at all this stuff.
There are groups that are studying prediction models based on CDH databases, but ultimately you have to depend on all the gestalt of the data that the patient is providing you to make these complex decisions.
It'll be really interesting as we get into really predictive analytics around, machine learning and artificial intelligence. What you could do is you start to really piece all these complex bits of information together to help you come up with some sort of true predictive score around the CDH.
Well, I don't know about everyone else, but I'm really grateful that I have this great group of smart people around me to teach all of us about all of these topics. And so I just want to give everyone a minute here to sort of give me a last thought about just their last take home important thing that they think they would want everyone to know about from the committee. We're all so glad that you were here today. We hope those of you that watch later can get a lot out of this. And so Adam, why don't you start? Any parting thoughts for the group?
Well, I mean, I guess I just say just specifically related to pulmonary hypertension. I think as we learn more and more about these complex kids and the kind of multidimensional nature of their illness, and as the medical therapies continue to evolve, I think keeping an open mind when you may get asked by some of the intensivists to do some things that may not quite seem like the normal thing that we're used to, because sometimes pushing that envelope and putting kids on ECMO or other things that might be out there, or who knows what the future may hold, will be really important. And so I'd say, as we learn more and more, as the technology continues to advance, just to keep an open mind and keep wanting to learn about these things. I think that's really important. And that's just, I think, what most of us try to do every day to help our kids.
Howard?
I think my parting statement would be something along the lines of, one of the foundations of critical care training, in my view, is that you learn that there's way more than one right way to do things, and that the path to success can go through many, many waypoints. And so if you stay actively engaged with the teams that are helping take care of your children, and focus on the long distant outcome, on a regular basis, I think you can get lots of mileage out of just remembering the basics of physiology. And I think it's a fair statement to say, I won't speak for anybody else, but if someone is watching this later on and finds themselves with a question about a baby, and they want to just bounce ideas off someone that's not in their institution, I'm always happy to field an email or a phone call or whatnot. And my information's in the APSA directory, just like everybody else on this committee. And I actually enjoy the challenge of trying to figure it out and help get you to the end zone. So I think those are kind of my parting shots.
Sabina?
Well, just to kind of reiterate, Adam's statement about keeping an open mind. And I think what's very cool about what this committee does for the non-critically care trained surgeon is, I think the information we put out helps us become more facile and comfortable with ICU talk and ICU speak, and lays a foundation that allows you to have the confidence to have that open mind and to engage with our medical partners in a way that's meaningful and will hopefully provide the best possible care for our patients, because when you approach it with that multidisciplinary look, you can only come up with the best answers.
All right, Mike, and then we'll go to Alex for the last.
Yeah, my comments are all on the same theme. It's really just staying curious and staying collaborative. It's, if you come across a new or interesting problem in the ICU, it's going back and reading about it and figuring it out and asking questions and learning from, especially the medical ICU colleagues. As Howard said, there's multiple ways to do things, and it's spent a lot of time in the ICU, and I still learn something new every day that I'm in the ICU. And just be collaborative, really listen to everyone.
Yeah, I think I completely agree. Critical care is a team sport. We all have to collaborate with all of our colleagues. But in closing, I would like to thank APSA as an organization for giving us this opportunity. to share our knowledge. I would like to thank this committee for their hard work and brilliance. And I have to highlight Dr. Boomer for her organizational skills and her ability to herd us all into this great presentation. So I thank you all, and I thank you, Dr. Boomer. And as Dr. Samir said, Dr. Gattapali said in the chat, yes, the future of critical care looks bright. So congratulations, and thank you to the audience for sharing in this.